Thank you very much, Junko-san. Colleagues, all protocols observed to recognise all the many colleagues both here in the room and online. We just heard from Lady Rosalind Marauta. We are at a crossroads in terms of the response, the global response to HIV today. With 5 years to the 2030 target for ending AIDS as a public health threat, the global response is sorely being tested. This year, of course, US funding cuts have dominated headlines. But the reality is that there has been an overall decline in international donor support for development, for health, for HIV, and this has been happening over the last few years. So many of us have been asked and are asking the question during the course of APACC and at the upcoming IAS. So what happens should PEPFAR not be reauthorised between now and 2029? The Congress is currently considering it. We must recall that PEPFAR, the US government through PEPFAR, is the world's largest donor to HIV, and that itself is probably a challenge and a mistake of allowing a dependency on one major donor for a whole range of issues, but particularly for HIV. And so other donors were able to see that they could step back along the way as the world faced successes and progress against HIV. And all of us here know of the many successes that have been achieved. But as we just heard, what will happen if the global fund is not sufficiently replenished and if other resources are not found for the HIV response? Just based on the shortfall of funds from the US, UNAIDS projects that there would be an additional 6.6 million new infections and 4.2 million deaths by 2029. Our hope of an AIDS-free generation could give way to the existential threat that HIV has always posed. And we're seeing this starting to occur in countries already. So will the world rise to the challenge? Will we pick up the pace, containing the epidemics so the future response is affordable? Or will we stumble, throwing away the significant progress of the last 2 decades and creating a drain on future resources of countries? Sorry, I've got to go back one. Something wrong with the slides. Oh, it's okay. There's a slide missing, sorry. No, the second slide's disappeared. But when we talk about sustainability of the HIV response, what do we mean? Many obviously would focus on financial sustainability, the country's long-term ability to pay for programs. This speaks to how countries mobilise and allocate their resources. It is pursued with the goal of closing the funding gap while improving impact, efficiency and cost effectiveness. But there are 4 other dimensions of sustainability that we should prioritise. The first of these is political leadership, the decision-making that leads to a successful and affordable HIV response doesn't happen by chance. And as we see from the most successful countries, this is because of the political leadership over many years. And bipartisan, doesn't matter which government is in place at the time, they continue to support these important public health issues. There must be high-level commitment to adopt the required reforms and to maintain the momentum. A second area, complementary dimension of sustainability, is the enabling laws and policies. After 4 decades, we know that HIV is not purely a health challenge. The Global AIDS Strategy calls on us to break down the barriers blocking people from care and support. Countries have committed to removing punitive laws and policies which limit access to HIV services. They have agreed to lower the stigma and discrimination people living with HIV and key populations face. And they have promised to address gender-based inequalities, including violence. HIV services serve little use if the people who need them most feel safer away from these services, and this is a significant problem in many of our countries. The third area of sustainability is the additional element, services and solutions. We must not only adopt innovative technologies and design approaches to deliver them, but we must make them implemented at scale. It requires modernised prevention and treatment service delivery at this scale to have impact. It also means integration with UHC and other systemic approaches, including HIV and national health insurance schemes. The fourth element of sustainability is systems, covering the data, the labs, the procurement, the community leadership, and all the other interconnected components required for an effective response. The element is an umbrella for all workforce development, institutional preparedness, and infrastructure needed for programs to work. Our success is not only measured in our ability to keep people living with HIV alive and well. To end AIDS as a public health threat, we need a far stronger focus on prevention. This is the gap. New infections are like a leaking tap. I once had a general who was leading a country in this region meeting with public health officials, and he said to them at the end, "You're all busy playing with the pool of water at the bottom of the tap, but the tap is not turning off. You need to focus your efforts on the tap." New infections are like a leaking tap. Every drop in the bucket is another individual requiring lifelong treatment. The only way to ensure a sustainable response is to stop this flow. In the top graph here, you will see that globally since 2010, there's been a 39% decline in new infections. But if we take Africa out of the picture, what's left is a stagnating or deteriorating trend in regions with HIV epidemics primarily affecting key populations. To achieve the global prevention target, Asia-Pacific, with its huge numbers, its huge populations, will be absolutely critical. As the bottom graph shows, however, the rate of decline in this region is 3 times slower at 13% and has virtually flatlined and increased in parts of the region. There were 300,000 new infections, 1 every 2 minutes in 2023 in our region. Concerningly, some countries now have fast-growing epidemics. In the Philippines, new infections have increased 6 times since 2010 by 543%. New infections in Fiji have increased by 241% since COVID. In Papua New Guinea, new infections have doubled, and the epidemic has diversified into what we call a mixed epidemic, where more infections are happening in the general community than in the key populations. But even places where the numbers are falling overall, the rate of decline is too slow. Key populations, and particularly young key populations, are especially vulnerable. Since 2010, new HIV infections amongst gay men and other men who have sex with men across our region have increased by at least a third. Why is this happening? The information to the right of this slide summarises this perfect storm. While overall there is a high political commitment to fund treatment, there is limited will to invest in prevention. 4 of every 5 new infections occur among key populations and their sexual partners, and only 1/3 of these communities have access to prevention services. PrEP and community-led services remain highly donor-dependent and therefore now extremely vulnerable. For the most part, PrEP, social contracting and other differentiated or innovative services continue to be pilot projects, not yet delivered at scale to have impact on national or regional epidemics. For example, there is a 98% gap to the region's PrEP target of 8.2 million people by 2025. These are areas that we need to see renewed investment and commitment by domestic budgets at country level and by our regional partners. So simply put, countries are investing too little in scaled-up prevention. From a law and policy perspective, reform to advance access to prevention services and community-led programs are lacking. Our key populations remain highly criminalised and inadequate rights protections. So these challenges are compounded by what we'll see in the Global Fund cycle of 7, where we're looking at major reductions already, and all countries have received letters from them. So it's not just one donor, it's multiple donors and the lack of domestic investment. These graphs, and I won't go into these in detail, these show you the investments. Sustaining the gains requires long-term commitment to resources. Low and middle-income countries is becoming increasingly challenging. Worldwide, there's been a noticeable decline in international donor support, as I said earlier, while some countries continue to face domestic fiscal constraints. The top graph shows the resources by source in low and middle-income countries between 2000 and 2023. The bottom graph is our region, between 2006 and 2023. Clearly, the donor funding has been crucial, particularly in those key areas of innovation for service and for prevention in particular. It's the declining trend, represented here by the shades of red, highlights the urgent need for countries to transition now to more sustainable, domestically driven HIV financing models. Again, the need to invest and take away from siloed programs by linking to UHC and other programs. The same for TB and other issues. The blue bars reflect the domestic funding, so you can see where that is, and it's largely for treatment. The last two slides I'd like to quickly look at are about our region in more detail. The region's high donor dependency for prevention is now a crisis. The blue bars in the top graph show the low proportion of funding allocated to key populations in most of the countries we've analysed. On average, less than 15% of HIV resources go to these interventions. So if we think we're going to treat our way out of this epidemic, we are sorely mistaken. The bottom graph shows international versus domestic funding in 17 countries in the region. Now, when we think of PEPFAR, the PEPFAR funding to the Asia-Pacific region, which includes Eastern Europe, Central Asia, except for Ukraine, is half of what the funding is to Malawi. So it's not massive amounts, but it's highly targeted to where it'll make a big impact in those different epidemics. So it's technical and financial contribution together. We need to see other countries stepping up in this region where they have an interest in the region to help overcome the gaps that are going to occur between PEPFAR and the Global Fund. So as you can see, 12 of these countries rely on international sources for more than 50% of their prevention services. But it's not all doom and gloom. We have great examples in our region. You look here on this slide, we can see what sustainable responses could look like. Thailand, a model for integrating HIV services into universal health coverage and scaling up social contracting to leverage the reach of the community organisations. They fund prevention, treatment, and the community organisations to deliver. JICA worked with us and Thailand to show this model to other countries in the region prior to COVID, and we need to pick up on that through the new knowledge hub that we just heard about to share these examples wider for countries. They already cover the funding of 90% of their response and are developing a sustainability roadmap for the remainder. India offers another example of progressive public policy to uphold the human rights of people living with HIV, key populations, and they fund over 95% of their funding. The Philippines also shows that it's possible to mobilise domestic resources for prevention, but it's getting it to scale that's going to be the challenge. In Vietnam, another example of integration into national insurance. Cambodia, high-level commitment, still a bit too much dependent on international resources. And in Malaysia, we find an example of diversified domestic resource mobilisation that targets the private sector. So we can learn from all of these and other examples to make the right mix in different countries. So friends, we know what to do. The time for cherry-picking sustainability strategies is over. We must act now to enforce all relevant best practices and to keep the hope of ending AIDS alive. Thank you very much.